Okay, guys, so we're gonna roll with chapter 32. Last week was um, we ended on chapter 31, which is environmental emergencies. Now we're gonna be talking about OB and pregnancy. And so, with that said, I'm actually going to start. I'm going ahead a little bit. The flow of the slides of this teaching didn't really flow the way I think it should. So we're going to skip ahead to the, if you're in your book, go ahead to the physiologic changes in pregnancy, and then we'll go back to the beginning. But it seems like this is where it should start anyway, versus the other parts. So, with that said, we're going to start with the changes in the reproductive system, the way the organs change. Uh, 9 months of pregnancy, 3 months, 3 3 month trimesters, and really when it's said and done, it's really about 10 months um, that the woman is pregnant, not necessarily nine by the time everything's said and done. So, but 3 3 month trimesters, and the placenta, which is the first thing that changes. Basically, it's the barrier and storage between mom, the baby, and mom. And so, where it's located is kind of is a barrier, works like a barrier, but it also has to be attached to this wall um, inside the inside the mother. And if it gets dislodged, which we're going to get to later, it causes some severe problems. But however, the fact is whatever is in the mom, nutrients, food, nicotine, alcohol, all that is stored in the placenta, and that's what goes down to the mother. So the oxygen, the nutrients, um, it's a but it's an exchange area between mother and the fetus. So whatever's in the mom goes through the placenta to get to the baby. And simple fact is, there's some departments, EMS departments, that it's in their protocols to give Narcan to newborn babies because if the mother's been on drugs during that pregnancy, the baby's been on drugs during that pregnancy, and so it's literally something that it's in their protocols. I've never delivered a baby, uh, and I don't care to ever do that, but I have showed up to a premature birth in the home, in the bathroom of a mother's home, to assist. Um, the baby was like 25 weeks, and so it's way premature, and the baby wasn't. We had to do CPR, we had to do the whole 9 yards. Baby's alive today, so that's pretty exciting. The baby's alive, but was taken away from the mother because it was ended up being a meth baby. So the baby was premature because the mother was on meth, and we did CPR. We did everything we could for the baby, and obviously resuscitated him and flew him out. But Narcan was one of the things that we administered to that baby because the mom was on meth, and so therefore so was the baby. You're talking it's premature, but let's say you go full term. That's 9 months of a drug addict, of the baby being able to that's been taking drugs. So now the baby's born, and cold turkey going without drugs. It's a scary deal. So a lot of places give Narcan. I'm still working out details here if that's something we'll do here, but definitely should be in our protocols because we don't see a lot of births here, obviously, but um, it's happened here in Cheyenne County. So anyway, so anything between the mother or anything that's within the mother's system, nutrients, oxygen, all that stuff goes through the placenta to the baby. Um, so they got the umbilical cord, which circulates the blood. Um, anyways, it comes out with delivery of the baby, and it's connected from the baby to the placenta. You guys know that. Um, however, that one thing I want you to think about if you ever do deliver a baby is we don't cut the umbilical cord. The reason we cut a certain distance of the umbilical cord, we don't cut it straight at the baby. So we'll go through that, the measurements and all that. But anyway, the fact is that umbilical cord works like a vein. So anything we want to administer to the baby, we can inject in that umbilical cord like a vein. We can give IV, we can give pain meds, we can do all that kind of stuff through that umbilical cord. Um, so it's kind of cool. So the amniotic sac is the cushion. It's the baby floats around in there, and the crazy part is it's about 99 degrees in there. So the baby's warm, baby's floating around, baby's comfortable, and then we are born. And then can you imagine how tragic it must seem for that poor baby? But however, rule of thumb though is when you deliver a baby, you want the ambulance to be 99 degrees because that's where the baby's temperature is. Um, so less traumatic of experience on the body is 99 degrees. If you are not sweating in the ambulance, you don't have it warm enough. You will be sweating. You'll be profusely sweating. It's an extremely hot environment. Just the same thing they do in the OB, get it up to 99 degrees to deliver that baby. And so here's a picture, changes in the reproductive system. So you can see the amniotic sac, you can see the umbilical cord there connected to the placenta. Um, and really, when you deliver a baby, you have two different deliveries. You deliver the baby, and then you help deliver that placenta. You don't want to pull it out, so the mom goes through contractions again and bursts out the placenta. But you got the uterus, cervix, rectum, bladder, pubic bone, vagina. So structures of pregnancy. So the cardiovascular system is another thing that changes, and you see here increased blood volume, cardiac output, and heart rate. So with that said, you always hear when people say, "Oh, you're glowing," with pregnant people. And a lot of times people say, "Oh, I know you're pregnant," before they tell them because, "Oh, I could just see the glow," which is cool. There is a glow, but at the same time, what it is the cardiac output is doubled. It's actually about, I think it's actually about, your book should say, let me just check here. I'm not in the book, but let me just check. So, um, yeah, so your blood volume is increased by 50%. So that's quite a bit. So what you're going to see here is you're going to see an increase in blood pressure, which we're going to get to in a little bit later on in this chapter because we got to talk about hypotension with pregnancy, but they're going to be a little bit hypertensive in appearance because their blood volume is doubled by 50%. Because what you got to look at now that they're pregnant is really, and don't judge me for this comment, but the fact is they have a parasite. It's a cute baby. We're gonna love it. We're gonna raise it. But at the same time, when the mom's pregnant, it's really a parasite because it takes everything and doesn't ask anything. It just takes, 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 takes. So it pulls the blood, it pulls all the nutrients, it pulls everything out of the mother. So basically, the mom's blood has to double, and so what you're going to see is you're going to see a higher heart rate, and I think that's the minute volume is roughly 40%, I believe. But you can check your book on that. But I believe it's 40% for. But anyway, so the minute volume increases, and the blood volume increases, and the blood pressure is going to be a little bit high, not too high, but they're going to be tachycardic. So one thing you got to look at that's going to be very important because you're going to deal with this, especially over on 287, is pregnant people that get in car wrecks. You're going to have trauma. So I want you guys to think for a second when you have double the blood volume and a higher blood pressure and everything's increased, what does that do for you? When you go on a trauma call, what does that do for you? What are you going to be looking for? Well, one thing that you're going to see, it's going to be harder to see shock in a patient because again, shock, right? They're hypotensive and tachycardic. So what you're going to see here is they have to, if they got 50% more blood in their body, the blood volume is that high because they're doing for two. They got to lose 50% of that blood. Then they're working on their own blood volume before that's got to decrease before you might even see shock. So you're going to have to, if that makes sense, I'm trying to explain it the best I can there, but you're going to have to see the early stages of shock as early as possible because you don't have one patient, you have two. You have the baby in the womb and you have the mother. So you're got to take care of two, and how you do is you watch her vitals to make sure her blood volume's in the right spot, her blood pressure's in the right spot, her heart rate's in the right spot, even respiratory system, it's increased oxygen demand and consumption. Um, so they're going to have some of those issues. So it's going to be harder to see those things. With the gastrointestinal system, they're going to be nauseous, vomiting, and slow digestive system. So just some things to look at right there um, when it comes to those a trauma patient with that's pregnant. So hormones. Here you see ligaments made more elastic, thus more vulnerable to injury. Um, excuse me. I've seen some car wrecks. I've seen some trauma with the pregnant mother, and a lot of domestic violence. I've seen a few of those, and I've never seen anything result from because they're elastic and this and that. But just got to keep that in mind. Their hormones are changing, so everything else is changing. The additional weight affecting posture, possibly leading to back pain and balance issues, which is why they fall a lot, or they can fall a lot. Because you got to look at the fact that um, that's a lot of changes going on in their body. And then pre-existing medical conditions can be um, affected. If they got diabetes already, well, that can get worse because now they have, there's two of them. She's feeding the baby and all that's going on, so it might affect the normal medical conditions. Um, and I've seen pregnant people that went diabetic just for the pregnancy and got better after. So things change. There's a picture of the changes. So, question for you guys is how far along do you think she is? Well, the simple fact is she's far enough along. Most people would rather drive the ambulance than be in the back with her because she can go into labor any minute. Um, but if you read these bullet points around, it kind of shows everything we've just discussed a little bit. You got this. So when you're transferring a patient, so supine hypotensive syndrome, remember that name. It's gonna be very important to you. You got to look at the fact that when you have a pregnant person, the placenta, the infant, and the amniotic fluid totals about 24 pounds. That's a bowling ball sitting in this woman's womb, in her belly. So when you lay her supine, it's going to affect that vena cava. We've already discussed this in class, but when supine, mass compressor, inferior vena cava. So it's going to decrease the blood flow because that is, you're laying flat and you're basically just dropping a bowling ball on that. The cardiac output's going to decrease, dizzy, and dropping blood pressure. So now you're looking at those vitals. All that's going to start decreasing because blood's not flowing because we pinned off that vena cava. So want to lay them in a recovery position, up a little bit, so that doesn't happen. So think about this: how does the development of the fetus affect other body systems? So look in your book and just kind of answer that question for yourself, because it changes quite a bit of stuff. Like I said, there's a parasite, and I know it's offensive. I'm not trying to be offensive if it is offensive, but it's just a baby. It's cute. We love it. I got 5 of them, and you know what? When they're born, they still take everything. So it's kind of a good example, a good description. So labor and delivery. Yeehaw. So the stages of labor is first stage, starts with regular contractions and ends when cervix is fully dilated. Okay, so the contractions begin. Now there's a big difference between a contraction and a Braxton Hicks. So Braxton Hicks is contractions, but not the same. It's usually caused by dehydration and overexertion. But when the contraction is going on, the whole abdominal area is tight. It just is hard as a rock. Um, and they last, when they start to get to be 5, 4 minutes apart, we get it's time to get busy. But the second stage, baby enters birth canal and is born. So now the baby's locked in and ready to go. And then the third stage begins after baby's born and ends when after birth is delivered, which is the placenta and all of that. So again, it's important to understand first stage, second stage, third stage. So as EMS providers, we don't have any way to gauge if they're in first stage or not. So if you have a woman who feels like she's in labor or you're running on her on a call, it's okay. Just assume that they're in first stage because we don't have a way to tell if they're dilated to 10 or not. We had a guy come out to our EMS team meeting a couple months ago, kind of taught us how to check for dilation. But let me tell you something: it's not your job. We're BLS providers, even paramedics. It's not their job. So I'm not checking dilation. And what I'm going to worry about is protecting the mom and just being cautious with the baby. So in the first stage, it's, when it gets to the second stage, that's the point where the baby's in the birth canal, the cervix is fully dilated, and now she's going to begin to push. And that's how you know you're in second stage. So again, it's not our job to leave it alone. Don't worry about dilation because we're not doctors. We're not OB. We're just EMS providers. Take care of that mother and be ready to take care of the baby if it comes, but be ready to deliver if she gets to second stage. So if contractions are going on and you're transporting a baby or a pregnant mother and the contractions are going on, if she's not, if the baby's not locked in the canal and she's not pushing, you got time to get to the hospital. Keep transporting. When the moment that it enters that where the baby's locked in, which they can be locked in for a long time, but now she's like getting that feeling to push, and I gotta push, and she's pushing because usually, the crazy thing is OB's scary, but our bodies have been designed to give, our bodies have been doing this for a long time, so the body knows what to do. So if the body's beginning to push, you're in second stage. So just an FYI on that. And then the third stage begins after the baby's born and ends when after birth is delivered. So that's the natural way. That's how it takes place. We'll get to some problems that go wrong later on, but I just want to make that clear because sometimes we get overthink it. Not our job to worry about dilation. Just take care of the mom and be looking for second stage. Okay, so now the first stage, going through the stages of delivery. Braxton Hicks contractions. I kind of briefly mentioned that earlier. Irregular, not sustained, and not indicative of impending delivery. So these can happen for a long time. I know Lori with Isaiah, our first child, she had a lot of Braxton Hicks during the last trimester, and it was really annoying because Braxton Hicks can scare a mom into thinking she's in labor. But one way to tell on this is if you're on a call or even yourself later, if it's a Braxton Hicks, what I always learned and was taught is you can talk through a Braxton Hicks. So you can talk through it. Now, a real contraction, man, it takes the mom's breath and everything away. All their focus goes on that contraction. So that's one way to gauge a Braxton Hicks is just how are they responding? Can they talk or can they laugh their way through it? I mean, it's not that funny, but you know what I mean. There's ways of distracting. It's like a distractible injury. Um, so with that said, is they can distract their way better. Now the lightening after this is when the fetus moves from high in the abdomen wall toward the birth canal. So this is like loading a gun. Basically, it's like the baby's in the upper abdomen and bouncing around, flipping around, woohoo, and you can always see that with babies get bigger. Mom's like, oh, feel my belly, and the baby's spinning and kicking and doing all that great stuff. Well, um, they can actually spin all the way till they're locked in that birth canal. So once they get locked in that birth canal, they're there till birth, till they're done. And it's actually a lightening is the abdomen. It feels different. Like all of a sudden the baby's in the position. Moms can breathe a little bit. Things are a little different. Contractions of the uterus produce normal labor pains. Well, how do you tell the difference between a Braxton Hicks and contractions besides talking your way through it? As you can feel it. Um, feel the abdomen. Feel the stomach. And you, with your hand, can feel the contractions. You can feel that tension and that change taking place. So characteristics of labor pain when you're in the first stage, contraction time or duration. So contraction interval or frequency, when they last 30 seconds to 1 minute and are 2 or 3 minutes apart, delivery of the baby may be imminent. So what you want to do here is once there's a first contraction, write it down. Start the clock. Sorry guys, I hit the wrong button and everything just took place. So you start the clock, right? So now they have their first contraction that you're present for. You start a clock and then you time how long the contraction lasts. And when it stops, you stop that clock. But you maybe start a lap clock because what I mean by that is you want to know how long the contractions are, then you want to know how far apart they are. So the time of the contraction from beginning to end, and then from the end of that contraction to the time of the next contraction, how much time is there. So basically, if you have what it says here in the slide is true. If you have a lady whose contraction is 30 seconds to a minute, and they're 2-3 minutes apart, you're delivering a baby. Congratulations. Okay, so wherever you're at, you're delivering a baby. Preferably, this, the contractions are like vitals, so get them on scene. Because if you're in the living room and she is getting ready to have a baby, contractions are 30 seconds to a minute, and they're 2 3 minutes apart, and she's getting ready to have a baby, you want to do that at their house. The last place you want to have a baby is in the back of the ambulance. There's not room. There's not. You're going down the road, and then you got to stop and pull over and have a baby, and it's a mess. So the best place to do it is at their house, if they're or wherever they're at on scene. Um, if that's where they're at, 2 3 minutes apart. So the breaking of the amniotic sac, you want to check the fluid. It should be clear, um, fairly clear. I mean, it's not crystal clear, but it should be fairly clear. The meconium is a bad thing for the baby, because basically what that is the baby was pooping, and then the baby was breathing all that in, and so the meconium is not good for the baby, obviously, to breathe in. There has been some research to say it's not as bad as it used to be or what they thought it was, but at the same time, what you got to look at is the reason the baby might poop, though, is stress on the baby. So long deliveries or whatever, or we don't know, or the other side is you don't know when they pooped. Um, they could bring that meconium in for a long period of time. Excuse me. So basically, just want to check that, make sure the meconium staining is not there, and that the fluid is clear and ready to go. So there's first stage, and then a second stage, and a third stage. Yeehaw! 3 stages of labor. So you can see there in the first stage, baby's kind of locking in. Second stage, baby's like birthing. The cervix is fully dilated, and the baby's coming out. And the third stage, you're gonna birth that afterbirth, the placenta, and all that. All right, so full dilation of the cervix in the second stage. Um, like we said earlier, you're not gonna know where the cervix is at. So basically, what you're gonna look for is if the mom is continually in contractions and they're frequent, and her pain is a 10 out of 10, and she's feeling an urge to push, you're in trouble. That's basically the way we're going to look at it, because you're not going to look at the cervix. And I mean, you can try, but like I said, we're not OB docs, to kind of avoid that maybe. But the contractions will be pretty severe, and it really, if they're if the mom's feeling the urge to push and she says that to you, um, you know, you're getting ready to go for a ride. Really, you're going to have a baby. Um, EMTs will have to decide whether to transport the patient or keep her where she is and prepare to assist with delivery. So with this, you're going to see this question, and my registry sucked because I had a lot of. I mean, my it was majority OB, and with the registry test, it's hard to say. Was I just answering so many of them right that they kept going, or was I just that stupid that I wasn't getting them right enough for them to move on? I don't know, but I had a lot of OB, cardiac and OB. But you're going to see this on the final here, and you're also going to see in the registry where they ask you to make a decision whether you're going to stay and deliver or you're going to go. And just like all of them, ABCD or ABCD, you're going to have two that are stupid and two that are going to basically state for you to make a decision: do you load and go or do you stay and deliver? So, two answers that I can say right now would for you to choose to stay and deliver would be 30 seconds to a minute of a contraction. That's all the duration, 30 seconds to a minute, and they're 2 to 3 minutes apart. If they're that, you're staying to deliver a baby. If the mom's crowning, if that's an option, um, you're staying and delivering a baby. So right there is a baby being born, obviously, but basic crowning is the head is on its way out, and so you don't have the chance to move. Third stage is after baby's birth contractions resume until placenta is delivered. So in your book, you see the placenta being born, and usually lasts 10 to 20 minutes, really. And there it is, the placenta. So guide the placenta out as it begins to appear at the opening, and drop it in a bag or something. Um, but really, you're not done with your job until that is born. Think about it. Why is childbirth such an exhausting ordeal for the mother? Wow, let's not even worry about that. Assisting the childbirth, the video, can't watch it. So now let's go through normal childbirth, and then we're gonna go through some bad childbirth, or things that go wrong. So your role is to deliver babies, or not to deliver babies, but the mothers do. So your role is to determine whether the delivery will occur on scene, and if so, to assist mother as she delivers her child. You're not delivering a baby, and that's not hard to understand. You don't. As EMS, we're there for support, and really, an OB doctor who gets paid tons of money. I mean, ridiculous amount of money. They're there for support. The mother's doing the work. You know, I mean, back in the day, moms delivered babies in the field. They didn't even go to the doctor. They delivered the baby, cleaned themselves up, and went and lay down for a while, took a nap, went back to work. I mean, we live in a different world now where everything's got to be sanitary and taken care of, but the body knows what to do. So you're basically there to support what the body's doing, and then to intervene if something goes wrong, which 1% out of 100 they do, and you'll have to be ready for them. So preparing the mother delivery is control scene. You want the scene protected and safe and respectable. I mean, you don't get much more vulnerable than having a baby. So you want the, looky loos away and everything. Chances are you're going to be in their house, but just in case you're not, make sure the scene is okay. Wear proper PEE. My gosh, you're going to want proper PEE. Goggles, a spacesuit, whatever you want. I recommend a spacesuit. Place mother on bed, floor, or ambulance stretcher. You can do it on an ambulance stretcher in the house. Like I said, you don't really want to do it in the ambulance unless she goes in labor. And I mean, the only way you would deliver in an ambulance is if she was fine at the house, went into severe labor at first view, and you got that much time, pull over and deliver the baby. I have one friend who went from 0 to 60 just that fast, and they had their baby in a bathtub. So you might have that. So stretcher is okay, but really bed or floor. Remove clothing obstructing the vagina. So it's like trauma naked. Cut everything off, and be ready to roll. Position assistant and OB kit. So get your partner. Make your plan between you and your partner. Make that plan and be ready to go. And then OB kit. And each ambulance has their own OB kit, and we're gonna probably update them soon. If possible, make environment as warm as possible. Okay. Like I said, about 99 degrees. And there's some options. Your OB kit has all those things in it. You got the little suction, the scissors, a little hat for the baby, things to help cut the umbilical cord. There's clamps for that, some 4x4s, stuff. So prepare the mother for delivery, off-duty delivery supplies. So, off duties, you want clean sheets of towels, heavy flat twine, or new shoelaces. And what that's going to do is that's for going to help clamp the umbilical cord. Towels or plastic bag for the placenta. You want to put it in something. Clean unused rubber gloves and eye protection. Head covering for the baby. So if you're not on duty and you're delivering a baby, those things will work just fine. The shoelaces I never heard of for the umbilical cord, but I've heard of flat twine, zip ties, those kind of things will work good. Are there legal, moral, ethical concerns for an off-duty delivery? Think about that. Where would you fall? We'll go back to chapter 1 or 2, whatever it was. Think about where you'd fall under that consent form. Delivering the baby, position for constant view of the vaginal opening. So, get the mom and you positioned in a way where you can see what's happening so nothing takes you by surprise. Be prepared for the patient to experience discomfort. Even the fact that that's on there as a bullet point is pretty ridiculous. Be prepared for the patient to experience discomfort. Really, provide emotional support and communicate with patient through contractions. So main thing is keep communication going. Do not panic yourself. Just like I keep related to a trauma, it's not a trauma, but it is traumatic for the mom. But want to communicate what you're doing, especially with the vulnerability of the situation. Always be communication. Don't touch her without telling her you're going to touch her, and keep yourself calm so you can encourage her. Because pregnancy in labor. It's going to be a scary deal for them, especially if it's the first one. So just be there for support and communicate. Delivering the baby, assisting with a normal delivery. Keep someone at the mother's head, so someone is talking to the mom, keeping the airway going, or make sure the airway's open, everything's going fine there. Position gloved hands at vaginal opening, so you're gonna keep your hands there when baby's head starts to appear. Place hand on baby's head as it bulges out of to prevent sudden uncontrolled expulsion. Place one hand below baby's head as it delivers. So one thing you're gonna do is, yeah, you're gonna watch the baby come out. It's probably gonna come face down, is usually how it goes. You place one hand on their head, but as the baby's coming out, put some pressure on the mom too. That helps keep the doorway open a little bit more. It'll help prevent some tearing um, and ripping and that kind of stuff. So just kind of put pressure on the bottom of the opening and one hand on the baby's head as it comes out, and don't pull the baby and don't control the baby's movements. Let the baby come out, let the mom do the work. You just guide your hand with the baby as it comes out and then catch it as it's finished. But that pressure will help cause trauma to the mom. Assisting with normal delivery, if the amniotic sac has not broken at time of delivery, use your fingers to puncture the membrane. So maybe the baby's being born, you can see that sac's not broken. Go ahead and break it, and once the head delivers, check to see if the umbilical cord is wrapped around the baby's neck. So basically, picture in your mind is when the baby's coming out, you got one hand there, one hand giving pressure. The head comes out, immediately check the neck, see if that umbilical cord is wrapped around. Because if it is, you can grab usually one of your fingers and see if it's loose enough to pull it around the baby so it is no longer around the airway, which will cause a problem. And then as the baby comes out, help deliver by you got your hand, one hand on the head, and then put another hand on the shoulders and just kind of hold firm and support the baby during the entire process. So basically, you follow your common sense. It's natural, really. And we're going to practice this in class right after Thanksgiving. So, yeehaw! Um, but support the baby during the entire process. Assess the airway and use syringe to suction mouth and nose if necessary. So, as you catch the baby, you're around the shoulders maybe now, and you check that airway. Go ahead and give a couple suctions, nasal and in the mouth, and note the exact time of that birth. Ta-da! And like I said, there's a great picture. And we are actually really going to practice this. We have a mannequin that delivers babies. And so we will play around with that. So the neonate. As soon as they are born, protocol usually calls for nothing. Protocol usually calls for noting ease of breathing, heart rate, crying, movement, and skin color. So these you're really going to have to know for your test. Okay. The APGAR score does not guide resuscitation efforts. Based on appearance, okay, pulse, grimace, activity, and respiratory effort. So it does not guide resuscitation effort. So as soon as that baby's born, you lay it down and check the pulse, check the grimace, check the baby's activity. Is it crying? Is it moving? Is it look? And the respiratory effort. Is it labored or is it not labored? So you'll put them in this kind of position and touch the foot, put your hands on them a little bit, and see how the APGAR score notes. So obviously it's just like Glasgow, but for babies it's APGAR. How's the appearance? How's the grimace? How's the pulse? How's the airway? Keeping the baby warm. Heat retention is high priority. Dry baby, discard wet blankets. Wrap baby in a dry blanket, infant swaddler or space blanket. Cover head and encourage. Encourage. There you go, baby. There you go, baby. So keep the baby warm. Okay, is the main thing. A lot of that heat's going to escape, like we talked about in one of the chapters last week. All that heat's going to escape from the torso and the head. So you put a hat on them, throw up in a blanket, keep them warm. So when you cut the umbilical cord, this is a big deal. So it's not huge. Dads can do it, whatever. Circumstances necessitating cutting. If cord wrapped around baby's neck and cannot be slipped overhead, you want to cut it. If attachment impedes resuscitation effort, you want to cut it. If attachment interferes with urgent need for transport or mother or baby, you want to cut it. And if protocol requires it. So You don't want the baby in danger, but at the same time, you don't want to cut them off a food supply. So I don't want to cut that if I don't have to until the baby's born. So if you can get that umbilical cord around the neck, if it is there, that's the best way to go. Cutting the umbilical cord steps is keep infant warm, and then you're going to grab some sterile clamps, or even there is in our kits sometimes they have tape. But apply one clamp about 10 inches from the baby. So, like I said, 10 to 12 inches. I mean, test purposes about 10, but if you're 12, it's not going to kill anything. Um, put a clamp, and then place a second clamp about 7 inches from the baby. So basically, clamp 10 inches from the baby, and then take your fingers at the clamp and drag, not hard, but kind of put pressure on and drag your fingers 7 inches because you want to push all that blood and all that fluid that's in there away from where you're going to cut. So just like trying to get water from, I don't know, from a hose or whatever, just kind of clamp it 10 inches from the baby, and then on the outside of that clamp, squeeze and push 7 inches away from that clamp, and then clamp it again, and you should have minimal fluid in that spot. And again, we'll practice this, so hopefully, it make more sense. And then go ahead and cut the cord between clamps using surgical scissors. And then what you're going to do is move the baby so no trauma is brought to the clamped cord. So you're going to be careful with how you're cutting it, but really, if you're 10 inches from the baby, you're going to be fine. And then place the baby on the mother's abdomen after the birth process. Let there be a bonding experience that starts. And so there's an example there, 7 inches and 3 inches, and so basically 7 inches from the baby, and then kind of a 3 inch gap there from clamp to clamp, and then cut in the middle. So resuscitation, provide warmth and assess baby's airway. So establish that the baby is breathing. Evaluate respirations, heart rate, and muscle tone. So if shallow, slow, gaspy breath, excuse me, sorry guys, or absent, provide positive pressure ventilation at a rate of 40 to 60 per minute. And we have actually baby BVMs, neonates. So 40 to 60 per minute, that's a lot more than what you're doing for an adult, right? So remember that with neonates, everything is faster. So if they're shallow, gasping, or absent, you want to give some positive ventilation at a rate of 40 to 60 per minute. But so basically when you grab the baby and you evaluate respirations, heart rate, and muscle tone, so kind of see how their muscles are doing, how's their activity, the ABGAR score. So just kind of check everything out and then provide air if needed. Assess infant's heart rate. If it's less than 100 beats per minute, that's bad. So if less than 60 beats per minute, we have to initiate chest compressions. So, a lot different than an adult, right? Because we're 60 to 120. So if we're below 60, we're not totally worried. But if less than 60 beats per minute, we got to provide compressions at 120 compressions per minute. It's a neonate, so it's harder to do. Remember CPR class, you hold the baby and you use your thumb. So if adequate respirations and a pulse greater than 100 beats per minute, reassess the airway. Go back to the airway. So drying, warming position. This is a neonate triangle. Basically where you start is basics: drying, warming position, suction, tactical stimulation. Give them some oxygen if need be, bag mask, ventilation, chest compressions, intubation, medication. So what we can do is everything to the intubation, which is no different than any other cardiac arrest. So we're going to dry, we're going to check the stimulation, we're going to start giving oxygen if we need to, switch the bag BVM mask if we need to, if nothing's working, and chest compressions. And there's a good picture right there. Liver chest compressions, mid-sternum. So basically, you're gonna, if you're in the ambulance, you're gonna sit on your stretcher. If you're at the house, you want to be kind of away from the mom at this point. But you just basically, put your palms on the sides of the baby, and right at the same place you put your palm when you're doing CPR on an adult, and just boom, squeeze your thumbs, push your thumbs down. 1 and 2 and 3 and 4 and 1 and 2 and 3 and 4. And you want to do it all the way to 120 beats per minute. So it's not fun doing a CPR on a baby. Um, but at the same time, just remember it's just a baby, which is important, but it's just a machine that needs some help. So go through this checklist. What are the first steps of neonate resuscitation? What is central cyanosis? And when is artificial ventilation required? And what is the rate of artificial ventilation? So remember, artificial ventilation is 40 to 60 breaths a minute. Um, and then your first steps is you're going to dry and check for responsiveness, and then check the muscle and the heart rate and all that. So just go back to that pyramid and caring for the mother. Mother at risk for serious bleeding, infection, and emboli. Deliver placenta, control vaginal bleeding, and comfort. So um, when you're delivering a placenta, you're going to kind of help the mother with contractions. So kind of in the middle of the stomach, it's going to be full of fluid and all that. So you're just going to begin pushing into that abdominal area, okay, massaging it and kind of coaching that contraction and coaching that placenta to move forward. And then you're going to guide it just like you do the baby on out of the vagina, and then you're going to place it in a bag. And there might be some vaginal bleeding, and if there is, you treat it like any other trauma. You know, stop the bleed, pack the wound, do what you got to do to stop and control the bleeding, and then give comfort. Placenta with the umbilical cord, amniotic sac, membranes, and tissue lining uterus. Placenta delivery starts with labor pains. So may take 30 minutes or longer and begin transport in 20 minutes. So basically what I just said, you give it time, and then, preferably, they say 20 minutes, but, give it 20, 30 minutes, deliver the placenta, then start transport. So when it comes to the bleeding, control vaginal bleeding after birth, place a sanitary napkin over the mother's vagina opening. Do not place anything in the vagina. So basically over it to absorb blood, have the mothers lower her legs and keep but not squeeze them together. So keep them together but don't squeeze them together. So put something there to help catch the blood, absorb the blood. Um, Legs will help, but you don't want to squeeze because you don't want to put too much pressure or use those muscles yet. Massaging the uterus will help it contract, which I just said, which controls the bleeding. So after the placenta is born, you go back and massage that uterus. If it it kind of helps activate and contract, which will control bleeding on its own, and encourage the mother to begin nursing the baby. So all that's good, but the main thing is just some tricks that pick up here is we won't think of that uterus very much, but it's there. I just went through a traumatic experience as well, and it's amazing how it's designed. It shrinks back. So basically, if you massage it, it'll help contract it and shut down anything that might be bleeding. Um, Take vital signs frequently, every 5 minutes. Ask acts of kindness will be appreciated and remembered. But basically, every 5 minutes, be respectful, be kind, take vital signs and watch those trends. Make sure there's no internal bleeding that might, kick into gear. And then wipe face and hands with damp washcloth and replace blood-soaked sheets and blankets. So get rid of the dirty. And it's amazing that this is even in a PowerPoint because it's common sense. But clean yourself up. Take care of clean the room, clean whatever you got to clean. Take care of the mother. Check her vital signs every 5 minutes, and go from there. So let's go through some complications. Common complications would be the cord around the neck, unbroken amniotic sac, and infants who need encouragement to breathe. So, anyways, that's some common complications. Cord can be around the neck. The amniotic sac may not break right away, so you got to help that. And then sometimes the infants need encouragement to breathe. Some suctioning, pat on the back. You just got to watch, and every situation is going to be a little bit different. The breech presentation, most common to abnormal delivery more than anything else, is that the baby's breech. And it used to be back in the day that they would literally spin the baby around in the womb. And wow, talk about complications that could be from that even. So you don't want to breech delivery in a living room or an ambulance. That, hopefully we can get them to the hospital at that point. Um, so that, and everybody knows what breech is. That's when the buttocks and or both legs delivery come first. So risk of this would be the baby's too high in the abdomen. Um, Meconium staining often occurs. You're going to see that potentially because everything's not normal at this point with a breech baby. So look for the meconium. Maybe it can be too high up in the area, and there's a picture of it in your book where they're delivering this. I've heard of these being delivered in ambulances. I've never had to see it or do it, but I sure not would not want to have to deal with that at all. So read your chapter on breech. I'm trying to breeze through this now. I've taken a lot of time to do this chapter, so we can discuss this in class more when we practice. So I don't want to take up a lot of time. So read on the breech. Main teachings that I've had, because I've never seen a breech, is that you do not want to breach an ambulance. Um, let's get ALS involved right away. Limb presentation is when the limbs come first, protrudes from the vagina. So this means when you go down where the head should come out, it's particularly a arm or a leg, and common is a foot when a baby in breech position. So there's areas like you can see in your book where the baby's just sideways. He falls into the canal, or she falls into the canal and to lock in, but she's either upside down, which is breech, and in your book you see a picture where there's a foot and the other one's an arm because they're sideways. Well, you can't deliver that. That's not going to happen. So you need ALS support ASAP. That is not something you can do because if that baby, um, just picture how the damage that can be done. Um, Rapid transport is essential, and you cannot, like I said, you don't want to deliver in a pre-hospital setting, so you've got to get moving. You want to slow the labor down the best that you can, and there's some exercises in your chapter that shows things that you can do with the mom to put her in a position, but you want to move on from that right away. Um, Prolapsed umbilical cord. When the umbilical cord presents first and becomes squeezed between vaginal wall and baby's head. So, um, tough deal here because this is when basically the umbilical cord somehow moves ahead of the baby. So maybe the baby didn't drop in properly or whatever, but the umbilical cord's coming first. So the oxygen supply to the baby may be totally interrupted because that umbilical cord is the lifeline to that baby. So if you look here at this picture in your book, that head and that vaginal wall is going to pinch that potentially that umbilical cord. So oxygen is going to be deprived, blood flow, everything. So that's the crazy spot, and it can be definitely life-threatening when you see that happen. So elevate hips. You want to give oxygen. So the reason you're elevating hips is to push that baby back a little bit, let gravity work for you. Keep the mother warm. Keep baby's head away from the cord. So the best that you can do without hurting the baby, move that baby's head off that cord if you can. Um, but you do not want to put the cord back. So it's kind of like a ruptured organ, or non-ruptured organ, an organ. That's you don't want to when there's an abdominal injury, and you got the intestines hanging out, you don't want to push them back. But same with the cord, you don't want to push it back. So just try to let gravity work for you. Give oxygen to the mom, more perfusion to the mom, more perfusion to the baby, right? So keep the mom oxygenated, keep that baby breathing. Wrap cord in sterile, moist towel because it's kind of like a protruding organ. So wrap some moisture around it to keep it alive, and transport mother to hospital, continuing pressure on baby's head. So basically, you're trying to hold back labor. Um, Everything in her body is going to be saying birth, 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 right? But you can't. You got to slow it down. So you put pressure on the head, put the hips up, put her on oxygen, and then wrap up that protruding cord or the prolapse cord um, in moist towel. So multiple birth is when you have appropriate resources. Um, Clamp or tie cord of first baby, assist with delivery of second baby. Placenta and cord care are same as single delivery. Keep babies and mother warm. So strange it's even in here. They should have just put a bullet point. Do the same thing you would normally do for one, but do it for twice. So um, you want to make sure if you get in there and there's twins, well, and you find that out when you get there, page for backup, get another crew to assist you, but have appropriate resources. So then when the first baby's born, clamp or tie cord of first baby, and then wait and help with the other baby, and then bring out that placenta and cord care at the same way. But now there's going to be two potentially, or one, but keep babies and mother warm. Premature, keep baby warm, keep air clear, um, provide ventilations and or chest compressions, watch umbilical cord for bleeding, avoid contamination, call ahead to emergency department. So premature birth, like I said, I've worked one of those. It depends how early. Baby could be fine, but the main thing is give birth, open up that airway with suction or whatever way. Check ventilations, check for chest rise, pulse, and if they don't have those things, you're doing CPR on the baby. Otherwise, if they're bradycardic, you're going to want to do a little bit of CPR. After ventilations are slow, like we said before in the chapter, you might want to assist with ventilations to help. Um, Watch the umbilical cord for bleeding. A lot of times with premature, you might see some signs in the umbilical cord that it's bleeding, so they're not getting enough nutrition. And then you don't want them to get sick, so you want to avoid the contamination because they're, like I said, depends how premature they are. But basically, with that 25 week old, we had to do CPR. We had to breathe for the baby, and yeah, and had to get ALS moving to help. So want to look for those things, and be as efficient as you can with the CPR if you're going to do them. Meconium stains amniotic fluid, greenish or brownish yellow in color. So we've already said that. Meconium is that slime. So when a baby is first born, for the first few days, that's what they're pooping is meconium. So it's slimy, it's nasty, it's very sticky. Um, so you're going to see that in the fluid. So if the fluid is not clean, it's greenish or stained brownish yellow. That's what that is, and the baby's been breathing it potentially for a while. So do not stimulate infant before suctioning. So when the baby's born, um, head pops out, shoulders pop out, you see meconium, get the suction instantly and suction the mouth and the nose, then stimulate breathing so they don't breathe that stuff in. Again, though, research now is changing a little bit. For test purposes, that's what you do. It is changing a little bit now to where they're saying now, um, if they breathe, they breathe. Their immune system will fight it. So use your judgment. For test purposes, suction before stimulation of breathing. Maintain open airway, provide ventilations or chest compressions if you need to. Again, just check the vitals if they're not working, ventilations and chest compression. Transport as soon as possible. Um, when you have emergencies with the pregnancy, excessive pre-birth bleeding, one of the things that you can have is ectopic pregnancy. Um, and we'll get to ectopic in a minute. Seizures in pregnancy, miscarriage and abortion, trauma in pregnancy, stillbirths, cardiac arrest of pregnant women. Um, those are areas that we're going to cover real quick. So, main sign in unusual profuse bleeding. Abdominal pain may or may not be felt. Sometimes the mom will feel cramping where they get in the fetal position. Other times they can just bleed without pain. It says for signs of shock, again, if they're going to be profusely bleeding, you're going to see it in the shock patterns, but remember that with 50% more blood volume, um, you're not going to see the signs of shock that we would typically see with a normal patient for a while. So look for those early signs. Provide high concentration oxygen and transport. Provide high concentration oxygen transport. Place sanitary napkin over the vagina and save all tissue that is passed. So basically what you're going to have to do there is with the bleeding, you're going to cover it, but as you are checking it and reassessing, you're going to see tissue potentially, and you're going to want to keep that, take to the hospital to show the physicians to make a decision because potentially that is the baby. Ectopic pregnancy is the be alert for. So it's acute abdominal pain, can be referred to the shoulder, vaginal bleeding, rapid and weak pulse, low blood pressure, absent menstruation period. So really, what an ectopic pregnancy is it's basically when a fertilized egg is outside the uterus. It's in the wrong spot. The definition of it actually is an abnormal place or position. Um, so it's just not in the right spot, so it's going to cause these signs and symptoms. One of the things that you got to look at is there's some reasons why, um, but when they're in the wrong spot, obviously it's going to cause abdominal pain, vaginal bleeding, rapid and weak pulse, you know, low blood pressure. So right there, you got signs of shock, tachycardic, low blood pressure, absent menstrual period. Um, and there's some. It's an interesting thing that happens, but chances are, if the mom, you could ask them, have you had an ectopic pregnancy in the past? That's usually a sign. Fertility treatments that moms put themselves on um, can cause older age, inflammatory disease of the pelvic, um, surgeries, abdominal surgery. A lot of times with an IUD, if they've ever had an IUD put in, they can cause, because it's kind of like because an IUD basically is kind of like it's a birth control, but it can cause these complications. So there's a lot of things that can cause an ectopic pregnancy. Um, so just be thorough. You're not going to know on scene, hey, oh, this looks like an ectopic pregnancy. You're going to transport, but kind of give you some input to what some you can ask them. So treat for shock, transport, seizures in pregnancy, existing preeclampsia. So blood pressure is a big deal. So if the pregnancy has an elevated blood pressure, it can cause preeclampsia. Excessive weight gain, excessive swelling of the face, ankles, hands, and feet, because there's a lot of fluid buildup. There's a lot of retention, and then altered mental status, headache, or other unusual neurologic findings. So some things you got to look at is if they have preeclampsia, they're going to have high blood pressure because high blood pressure can help cause preeclampsia. It's a symptom, but that can cause seizure. If they have abnormal weight gain, um, that can add to seizure or be signs of seizure activity with pregnancy, altered mental status. I mean, obviously, right there's a neurologic issue. Um, so a lot of times in pregnancies, things can just go wrong, and you just got to be able to check for miscarriage and abortion. So spontaneous or induced, body aborts the baby, or you choose to abort the baby, um, but it will cause side effects of cramping, abdominal pains, bleeding. It can actually cause hemorrhaging kind of bleeding. Excuse me. Noticeable discharge of tissue and blood from vagina. So basically that's all it's happening is they're hemorrhaging. I mean, it's that that fetus that is in there is actually just bleeding out. And sometimes, like I said, it's from a miscarriage, or sometimes it's induced. They cause it themselves. Pregnant patients pulse 10 to 15 beats per minute faster than non-pregnant women. So, as we said, you're not going to see shock right away. So if they're typically running 80 beats per minute, they're going to be 100, 110, touching 115 beats a minute. Blood loss may be 30 to 35% before signs and symptoms appear, because again, their blood volume is 50% higher, so it's got to drop that much for you to recognize it. And ask patient if she's received blows to the abdomen, from domestic violence to a fall to a car wreck. Check those things because I've seen domestic violence cases where the act itself damages the baby, and you're going to have internal bleeding, so they're going to go in hypovolemic shock. But again, it's going to be harder to detect. Do not resuscitate if it is obvious the baby died sometime before birth. So if you deliver the baby and there's obvious signs, we treat it like any other DOA. If there's obvious signs of death, we don't resuscitate. Provide full resuscitation measures if baby is born in pulmonary or cardiac arrest. So they were alive, but the birth caused a cardiac arrest. Boom, get those compressions going right away and start CPR as you would normal. Prepare to provide life support. Provide emotional support for the family. So this is where you can call for help. Get back up there, get someone there for the family, and be ready to intubate the baby and cardiac arrest, CPR. So on this case, we might be doing CPR all the way to the hospital. Baby's on our life support. Cardiac arrest of pregnant woman. Chance to save unborn child. Um, begin. What you want to do here is begin CPR on the mother immediately. But if the uterus displaced uterus of more than 20 weeks, so position hands 1 to 2 inches higher on sternum to make up for shifting of the heart by large uterus. So basically, that uterus is all the way up to the chest wall at this point. Um, so your compressions will affect that uterus. So you want to definitely go higher than you would normally. So normally at the bottom of the sternum, go up 2 inches, begin compressions to try to protect that uterus while you're doing them. And then we're going to do CPR until an emergency cesarean section can be performed or you are relieved in your emergency department. So basically, what sucks for us is we're not going to do cesarean, and neither is KMH. So not a good thing here for our area. So if we have this, get ALS moving right away, get transported to KMH, doing CPR. Um, if the mom is just went into cardiac arrest, we have a small window to save the baby. Remember that whatever's going on with mom is going on with the baby. So if the mom's dying or dead, the baby is not too far behind unless we get that baby born. So we're basically going to treat that mom like cardiac arrest, do compressions all the way to the hospital, get ALS moving ASAP. And that's a sticky spot for where we're at. But, anyways, just we're going to treat it like any other cardiac arrest, except for we're calling for ALS support. Um, and I'll let you know during class more of our protocols with the hospital on that because we don't do cesareans in our county. So we're going to have to get help ASAP and do the best we can. So when we have bleeding in the vagina, treat it as potentially life-threatening because you can do a lot of hemorrhaging. Check for associated abdominal pain, 4 quadrants, what's going on. Monitor for hypovolemic shock. So I know I'm breezing through these pretty fast because some of them are just self-explanatory from what we've learned so far. So when sizing up the scene, observe for mechanism of injury, car wreck, um, horse riding accident, I don't know. During primary assessment, look for signs of severe blood loss and shock. So we're going to do our head to toe, stop, take care of life threats, look for blood loss, and monitor them for shock. Consider additional internal injuries. We always got to look at the fact that when there's a pregnancy and there's a trauma and there's bleeding in that vicinity, we got to look at internal injuries as a problem. So again, we're treating it like any other trauma, but now just remember we have 2 patients, not one. Treat immediate life threats. Do not disturb potential crime scene. Examine genitals only if severe bleeding is present. If it's not, lead up to the hospital. Discourage bathing, voiding, or cleaning wounds because we don't want to contaminate the scene. So a sexual assault, unfortunately, the body has evidence. So we want to discourage them from cleaning themselves up, even though that's all they're going to want to do. Fulfill mandated reporting requirements. We treat this serious, so obviously we got to go up the ladder and get proper authorities on board. So there you go, guys. You guys did good. That was a lot of slides. And again, we're going to practice this in class, hands-on, hitting it hard. So if you have any questions, text me, call me. Otherwise, we'll see you in class.